So good day all. I have the pleasure of introducing the next speaker. Dr. Chrestian studied adult neurology at Laval University. After studying in France, involved in the adult neurology program, he then oriented towards neuropediatrics and finished his training at McGill University. His interest pushed him to the Sick Kids in Ottawa under the direction of various specialists in neuromuscular disorders. Diploma from the member of the European Association of Neuromuscular and the French Neuro Association. He's now in Quebec City, and he'll present the current elements in congenital myopathies. And thank you. Well, actually, I was given a choice between doing it in French or English. I roughly looked at the audience, and since they have simultaneous translation, maybe I'll take the opportunity, but I'll be happy to switch along the way if you need to. So my topic is congenital myopathies. It's a topic which is very dear to my heart. Actually, a summary of the whole presentation is this slide. In one slide, you have the whole spectrum of congenital myopathies with patients with various neuropathies. So the goals of the conference are, first of all, to learn to recognize a patient that has a congenital myopathy, understand the various forms of congenital myopathies, learn the new diagnostic means of this group of neuromuscular diseases, and discover the advances related to these diseases. So briefly, we'll talk about physiopathology to give us a context, and look at the classification of congenital myopathies. Why do we talk about a plural now for these diseases? And the new diagnostic approach. And what's new in congenital myopathies? My goal is to surprise you. So for physiopathology, we all remember that the essential basis is the sarcomere. The muscle is composed of several myofibrils, and these myofibrils, there's a whole system and network with actually pockets. And I want to draw your attention, I'm sorry, the pointer doesn't go far enough. At the bottom on the triad. So you have all the various elements which are important, the T-tubules and the terminal cistern and triad and sarcoplasmic reticulum. So the muscle is composed of a thick fiber and thin fiber, so actin and myosin, separated by Z discs, and the contraction means that these two fibers cross each other and reduce basically the dimension of the muscle and generate a motive force. Now, the physiopathology of congenital myopathy is the stimulus excitation contraction coupling. So this is really based on the calcium. After depolarization, the neuromuscular joint will enter through a channel and will depolarize a calcium-sensitive receptor, which will relaunch into the endoplastic reticulum, the whole calcium reserve, and the calcium will connect to the troponin to allow contraction, actin, myosin, and generate the muscular strength. So all this means that all proteins are important in this system. Well, of course, and it's the knowledge, the microscopic knowledge of the muscle, which has allowed us to recently discover new forms of congenital myopathies. Now, the classification, before we spoke about structural myopathies, because the pathology was really important to classify these myopathies. And now this classification is changing because we're basing it more on genetics. We talk about 5 categories, the 4 major ones. Myopathies with inclusion or protein aggregate. You know, the classical one is Nemeline. The 7th one of this cardiomyopathies with cores. We sometimes talk about central cores or multi-mini cores. Also, centralized core or central nuclear congenital myopathies. And then we talk about congenital myopathies with fiber type disproportion and other more rare forms that are still being described. Now, if we talk about congenital myopathies with inclusions or protein aggregates, it's mostly myopathies with a problem in the interaction in the filaments, whether actine, mucin, that will induce a disorganization of the system, which will accumulate itself and which will give mostly nemaline. We can see the arrow here. So, electronic microscope, they're called rods. These rods are like crystalline, that are generally actin and myosin accumulations. What's interesting is the evolution of our knowledge in congenital myopathies, especially in nemaline. Before calling them classical myopathies, or with little evolution, the first paradigm, it changed in recent years. It's not true at all. Congenital myopathies can evolve, weakness can evolve, especially during teenage years. With the growth and the stress induced on the muscles, there could sometimes be a small decompensation of the myopathy. A classical form of nemaline myopathy is this long phase with orthopedic impairments. Now, severe forms, actually before we thought it was rather infantile and juvenile presentation, but there can be neonatal forms. Often they're presented by arthrogryposis, so multiple contractions, or sometimes severe hypotonia. There are less severe forms, and probably in this room, somebody has a congenital myopathy that doesn't even know. So often somebody who's never been very good in sports or not a lot of endurance, but that's been able to get through their activities of daily life without too much difficulty. This is the evolution of genetic heterogeneity. Well, there are new genes that I'll talk about later on, but we can already divide through our knowledge. Well, we can classify them before by order of discovery of the genes, and they're mostly genes related to proteins from the sarcomere and proteins related with the ubiquitin, which is the degradation system in the cells to eliminate the proteins. So this whole category, nemaline is 6 to 10, are now called ubiquitinopathies. Now the pathology is still present and important, and a good pathologist can help us. That's why, especially in Quebec City, we work with St. Justine neuropathologist, Dr. Justin, who has this expertise to help us orient ourselves. So some elements can lead us towards a diagnosis which is very specific. Like, for example, we have elements of CAP, small CAP disease, accumulation of nemaline or neofibril products in a portion of the sarcomere cell. They can orient us towards the 3 genes, and an electronic microscopy. When you see rods, it's almost an ACTA1. It's one of the most frequent genes of myopathies with nemaline. Now, core congenital myopathies is a really interesting group. It's mostly a problem of the excitation-contraction coupling. So in the physiopathology of the calcium and the management of calcium, in these diseases, now we're talking about a new category of disease. They're called triadenopathies, because of the deficits in the proteins, either for the sarcolemma, which is the membrane of the sarcomere, or a problem in the receptors, which manage the homeostasis of calcium that's intramuscular. Now the cores, it's a pathological description. On the coloration, the oxidative colorations, there was a region that was completely depleted of oxidative activity, so we can see really the white spots in the middle of the cells. This oriented us. What's extremely interesting is that recently we discovered that a patient with a core myopathy accumulated cores over time. So this patient, well, there were seriated biopsies in age. Some of these patients had biopsies over a long period of time, and as they got older, they accumulated cores. So this showed that it wasn't static, but it was a dynamic as a myopathy. Once again, in the myopathies with cores, the spectrum of pathology has broadened over the past few years. We were used to talk about light to moderate myopathy, sometimes with limb girdle problems. Well, now they're less classical. For example, severe contractured congenital with babies that are very weak, but all contractured, or neonatal presentations that are more severe with the respiratory problems, paralysis of the view, and some even they have, on the contrary, muscular hypertrophy or superior, above average muscular strength. So the main gene implied in the core congenital myopathy is the RYR1. It's probably the most frequent one for patients with genetic myopathies. The presentation can be dominant or recessive. We can need either one mutation or two. There can even be a certain intrafamilial variability. For example, in the case of this family, where the child was more severely impaired than the father had a mutation, well, the same mutation, but it didn't explain completely the phenotype. And by doing more research, we realized that the child had a second mutation in the RYR1 gene, which makes it even more complicated. So RYR1 can also give more pathological impairments. There can be central core anemoline. We can find forms with centronuclear forms. So the pathology is not perfect, and the genes can give a straddling amongst the presentations. So other genes were recently described, genes which are often, sometimes they have a problem related to the rigid spine, or there could be an expansion of the phenotype. Actually, in the program I saw that there was a presentation of a new form in New Brunswick, a titinopathy. So it's a youngster, a gene that's very long that either gives cardiac problems or problems with congenital myopathy, or early congenital muscular dystrophy, early or late. So it's extremely interesting. So the difficulty now of the clinician and a specialized neurologist is the straddling of the phenotypes. There are no more key elements which can orient us towards a specific gene. It's kind of more complicated. Now, congenital myopathies with centralized core. Classically, it wasn't difficult for pathology because normally the cores and the muscles are rather lateralized, whereas here they're internalized. The main gene is MTM1. It's the only CM that's currently related to X. What is very specific is that the mothers also have it less severely than boys, and they have a specific presentation on the muscle since they have necklace fibers. So this is pathognomic for the diagnosis, sometimes for certain parents, where we find a few elements of weakness, but with a boy that has a more severe deficiency and the parents wanted to avoid a muscular biopsy, we could do a muscular biopsy of the mother for these cases. There are other forms of biopsies like DNM2. They have a pathognomic presentation with radiant fibers. So it's an immediate diagnostic in this case. For example, I had a patient, 17 years old, who was being followed for congenital myopathy for several years until we reviewed his muscular biopsy, which presented these typical radiant fibers. So it's a diagnosis that could have been made many, many years ago. You just needed a good pathologist to be able to orient us. Once again, other genes in this category, BIN1, SPEG, RYR1. Now, the new approach for congenital myopathies, and we can see that the genetic arsenal and genetic sequencing has certainly changed our approach. This is a diagram which represents the classical approach of congenital myopathies. If you suspected myopathy, either through weakness or because of hypotonia or motor delayed, non-progressive or slightly progressive, and muscular enzymes within the limits of normal, we'd give a physical exam, we could determine certain characteristics, and if the muscular enzymes were not higher than twice as the normal level, we considered that we were in the category of congenital myopathies, and then the practice standard was to do a muscular biopsy. And the muscular biopsy would allow us to orient ourselves into the four categories that I mentioned earlier on. And if genetics was available, we would do the genetic diagnosis. Except the genetic diagnosis, as mentioned, has gotten more complicated, since many genes can present in various types for the muscular pathology, which means that biopsy remains useful, but maybe now is not as essential as it used to be. This is the new approach, actually, for congenital myopathies. So before we were able, using a few clinical signs to correlate with a muscular biopsy, to do a specific identification and to be able to orient towards one or two genes and therefore to limit the cost in genetic testing. Except recently, this approach was completely disrupted by gene sequencing and the new generation of tools, because we can now ask for panels, i.e. in a panel we can ask several genes from a category of congenital myopathies, and the cost-benefit ratio has increased. It's almost less expensive to do a panel than to do a muscular biopsy for a patient. Except sometimes the panel comes and demonstrates variants that have undetermined significance, so muscular biopsy also remains essential. So a new approach, which helps us a lot also, is the magnetic resonance imaging for muscles. We can see there are presentations, patterns that are very specific of muscular pathologies for reasons we don't understand, and which can relate to specific genes, as for example RYN1 for the thigh. There's the rectus femoris, which is very specific, almost pathognomic, but not for all mutations. This muscle is often spared. So finally, this is the complete algorithm for a diagnosis of congenital myopathies with an approach with magnetic resonance imaging for the muscle, genetic test, more or less muscular biopsy. It's not rare now that I'll do rather MRI and a genetic test before doing an invasive muscular biopsy. So you'll tell me that once again, the neurologist, it's excellent, he does excellent diagnosis, but doesn't change much from the point of view of therapy for our patient. And this is where my goal is to surprise you, because it's totally false. Once again, the spectrum of neuromuscular disease is dramatically changing as far as therapies, i.e. patients with central nuclear myopathies, which were secondary to the MTM1 gene. It's one of the most severe forms of myopathies, but it's also, the MTM1 is an enzyme, and currently there is a study to replace the enzyme, which is there to improve the outcome of these patients and even eventually to cure these patients. Also, central core patients, when we look attentively in the microscope, we can see that the neuromuscular junction, the junction between the terminal end of the nerve and the muscle, is dysmorphic. The muscle is so deformed that the collaboration between the nerve and the muscle is impacted, and we realize that if we put these patients under Mistanon, which is inhibitor, it can increase their function and their muscular strength. So it works very well, very useful for patients with central core patients of the most severe forms. For example, the same patient with, I put him on Mistanon, he increases muscular strength by 50%. 50% in a daily life, it's huge, because before he would regularly fall because his legs would buckle, but he can pick himself up and do his activities of daily life almost alone. It also had an impact in the ophthalmoplegic impact, where there was limitation of eye movement, but the eye movements came back totally normal. Currently, we're studying something else to see these. It's very gene therapy, which is very interesting. It's a gene therapy, as I presented for the previous presentation, to replace the missing gene by putting it in an adenovirus, which will go to the muscles and replace this gene, and which will allow the transcription of the protein. The model. To be able to do these studies, you need a model, an animal model, and one of the best models we have currently is the zebrafish, which has a single muscle, and this muscle, we're able to modify its genetics and, for example, to make it into a fish without MTM1 gene and study the effectiveness of the therapies. I wanted to show you a few elements that are very recent, just hot off the press for congenital myopathies. Mnemaline myopathy, a severe one, KLHL40. So they were put on to Mesinon, and it greatly improved. It's a baby that was severely impaired, so he was able to start eating and let go of the ventilator, and the baby was able to sit. So it was a major event for a myopathy which is severe. I wanted to talk also about the new genes. I'll go very quickly today, but especially the genes which appeared recently. So the myopathies with aggregation of tubules. So in the ORA1 and STIM1, ORA1 and STIM1, these two genes mostly ended up on the muscular membrane, and which managed the entry and the exit of calcium. So it was an interesting group, and they did a wonderful work because there was a microbiological work. There was a problem in the homeostasis of calcium and those myopathies, which really presented the same pathological appearance for the muscular pathology to identify mutations in these proteins. So it was really backtracking work, but which allowed us to identify several families, and it's mostly a group in Strasbourg in France which identified these two myopathies. Something which also changed a lot in my practice in the last year is the presence of mutations in the CACNase, the CACNA1S gene. This is a channel also which manages calcium, which is important actually in the coupling between the tubule and the renin receptor, and this gene, the CACNase gene, was also involved in other neuromuscular problems. So this was interesting to discover that it could also give congenital myopathies. And I found two patients, actually, who had a congenital myopathy of an undetermined cause, and they actually have a mutation, a homozygote mutation in this gene, CACNA1S. Explains the pathology, and it's interesting because this gene in the periodic parasite, if you can restrict potassium, it can help them, but also diuretics. For example, very simple medication can sometimes change the outcome of the patient. It wasn't yet tried for in case of congenital myopathies, but it's a therapeutic pathway which could be interesting. Now, if we look at categories with filaments, there's a whole category that was generated with a myosin. So we remember that the contraction system is actin myosin, but myosin, it's not a single protein. It's a whole bunch of proteins, and many congenital myopathies appeared in the past few years. So myosin 2, 3, 7, 8, KBTB, and 13. What's particularly interesting is that traditionally we said that a patient did not have a cardiac impairment, but since the spectrum has broadened, well, now we know that there are some genes with cardiac impairments, and even patients who have a known gene that doesn't have cardiac impairment, like ACTA1, can have a cardiopathy. So it also changed the practice, which means that all these patients have to be referred into cardiology for a cardiac assessment at least once before the age of 10 years to make sure there's no underlying cardiopathy, especially the MY7. It's a very interesting gene which gives muscular weakness that is distal, and which also gives a cardiomyopathy. That's also classical for an NY7. It's bending toe sign. It's the extension of the large. We can see it on the MRI that the large toe is. There's a adipose replacement, so clinical can orient us towards this gene. And the last part I wanted to show, the other cellular aspects. I thought it was particularly interesting to show the complexification of the neuromuscular diseases. Amongst other, the second gene, which is piezo2, by PIEZO2. It was a well-known gene that gave distal arthrogryposis or neuropathy problems with loss of sensitivity. And now we realize that there are forms of congenital myopathies which are associated to this gene. So once again, if we don't look for it, we don't find it. And its discovery And it's the advantage of genetic panels which now allow us to broaden our knowledge from the point of view of the spectrum of congenital myopathies. The other gene I wanted to mention, it's the SCN4A. Once again, it's a canalopathy. It's a receptor, the receptor which manages the entry of sodium into the cell. It's a very important receptor, since it allows to trigger the departure of a contraction excitation system. So normally you have congenital paramyotony. It's congenital, so patients will have difficulty to have muscle relaxation, but they'll have large muscles, sometimes paramyotony, which is accentuated during the winter time. So recently, actually, we had described also congenital myopathies with muscular weakness, and even one of my good friends who does OC Kids described a family with a recessive autosomal mutation in the SCN4A, and they have a specific pathology with corona fibers. So a new congenital myopathy that is severe. Now, what are we doing at the CHUL? And what's new at our hospital? We're fairly active. And two elements I wanted to present that were presented at the World Muscle Society. The first element is a single family had been described with muscular hypertrophy. And basically we discovered a second family, except its presentation, which is very rare, very specific. And with the help of our neurogeneticist, Dr. Laissez, I'm very lucky to have an excellent neurogeneticist with myself. We had included these patients in a second sequencing of exons to see, wasn't there be a second gene or a second mutation that could explain this muscular hypertrophy, and also an above average muscular strength. So Dr. Bernard Bray, for several years now, was looking for the syndrome of the strong man, and he'd even found a few interesting genes. And this family, which is quite specific, is that there's a family picture of the 4 men in the family over 2 generations. They're all lifting a tree trunk. It's exceptional. And I'm following 2 of the children of this family, and the boy, who's 15 years old, almost broke my arm by doing arm wrestling with me. So either he's very strong or I'm very weak, but anyway, it was an interesting element. And they present with cramps, huge cramps, very painful cramps. And when you read the biography of Louis Cyr, that's what's interesting, is that Louis Cyr was a strong man. He was extremely strong. And 2 interesting elements is at the end of his life, actually, he would complain of cramps and intense muscular pain. Secondly, he died of chronic renal insufficiency. And thirdly, his daughter was as strong as him, so probably she also had a genetic problem. So we were talking about autosomal dominant.
L'article est à sortir très prochainement pour cette.
This will be published soon for this family. Secondly, to show that we can change the congenital myopathies spectrum. Here's a patient. She had a X pathology, but showing multi-bodies. Only 3 genes are associated with multi-bodies, and it was negative. Eventually, we asked a panel, and we found in TNNT1 a morphing of the gene. It was only present previously in the Amish population with a lethal form, and it was a problem because we only had 1 patient with this monozygotus mutation, probably harmful according to prediction patterns, and she had a rigid spine phenotype with congenital arthros that got better over time. And there were a few recent publications and a few recent about TNNT1 mutations that showed the same phenotype, but in a population outside of Amish, so less severe. Unfortunately, I should have maybe asked the mother to come here, because what social media did was to change neuromuscular practice. I have a mother who's was very bold, and she typed T1, TN1, and she found a 45-year-old woman saying, "My neurologist diagnosed me recently. He diagnosed a monozygote shift in my gene TNNT1." And the lady asked to contact the neurologist in Ottawa, and she were surprised to see it was the same mutation and the same pathology. The lady is 45 years old. And so we finally described a new morphing of that gene, and probably that is under evaluated, and there might be a few in the Canadian French population that have this diagnosis. Publication to come. To show you now functioning and how we can diagnose these diseases. The case here of a case study of a 13-year-old seen last year by a colleague in a context of osteonecrose with a femoral head, a rather weak child with a motor delay, started walking at 2 only. His father was a truck driver, a mother healthy, and maybe a cousin for hypotony, but no follow-up. We see she has some of a heightened voice tone, no contracture, hypertrophy of the glutes, not very developed, quads and deltoids neither. Her hip was painful also because of nesonecrose. She had the surgery at the hip. What are the investigations? Well, we went through an MG, and then we noticed an EMG, and we saw it's myopathic. But the patient and mother refused a muscle bioptics. Unfortunately, during the hip surgery, we didn't have the opportunity to do it. And so we go through MRI of the hip. Surprise, we see that at the glutes. Sorry for the pointer here. There's a good fat replacement, and almost all muscles are part of this, except this part here. Eventually, the other muscles, abductor magnus, gluteus maximus, sartorius, but the rectus femoris was saved. Based on the clinical exam, we asked a sequencing of RYR1, and the lab says there's a mutation of unknown significance, a variant of unknown significance. And when we started looking into this, it's a very harmful mutation. And when we also look into the father, he has a slight myopathy. And when you assess also, when we find our colleague, the child was assessed, but there was no genetic testing. But there's a myopathy also. And we ended up seeing that all the family has the same mutation. This opened up possibilities of treatment. If there was even salbutamol or mestinon or dantrolene that can be used for RYR1. Current members of family have a slight muscle weakness and do not want the treatment. Also, genetic testing is important because RYR1 are more likely to do reaction to anesthesia, and recessive gene can also make spontaneous reactions to heat during the summer. Even so, intolerance to heat, they cannot go out, they feel weaker, they don't feel well, they need to be under AC. Congenital myopathics are not that rare. Muscle biopsies are not the only tool. There's now MRI for genetic panels, and we can think also that these myopathies can now be cured even in the near future. Also, in one slide, the landscape of genetic myopathies with several genes. To say how the approach is being standardized, there's very good guidelines that were published in 2013 on the approach for congenital myopathies, which I mentioned at the beginning of the presentation also. On top of this, but starting to be slightly old now, 2012, but the standard of care for congenital myopathies. A multi-systemic approach, cardio, neuropathic, etc. More and more, I want aggressive management, taking into account all the therapeutic options that can be now offered to patients, children, and young adults. There we have it. This was rather fast.